Senator White to introduce folks who are here in the room. We have this, so we are back live. This is Senate Health and Welfare, February 28th, hard to believe, really. So we're switching gears now. We're looking at Bill S-231 on pilot for community nurses. And we have a number of folks in the room ready to testify about what they're doing. We also have Jill Mazza Olson here, and she's going to go first after you introduce folks. So Senator White, why don't you introduce who we have here today?
Sure, I'll just come up. Thank you so much for having us. Senator Rebecca White, for the record, I represent Windsor County's district. Today you have the pleasure of hearing from 4 different folks, and you also have some written testimony that's on your website. You will hear from, you'll first hear from Jill Lloyd. She's going to represent Aging at Heartland, which is a phenomenal organization in our district, and she can tell you all about that. I won't steal her thunder. They've given you some handouts. You may have seen one of them before, which just describes Aging at Heartland. You're going to hear from Katie, who has the same last name as before, even though you just got married. Okay. Katie is our community nurse. And she can tell you on the ground what's happening. You've got Phil Hobby, select board in Heartland.
And on the board of Aging in Heartland.
And on the board of Aging in Heartland, and then you have Carol Langstaff. So you're going to hear some phenomenal voices on what the community nurses are doing and why they're supportive of this bill. While Heartland is very well represented in this conversation today, there's many different towns in Windsor County and throughout the state that have community nurses. And you might hear a little bit about that statewide representation as well. So thank you so much for having us, and I really hope you take the time to consider this bill.
Yeah, thank you. And thanks for introducing the bill. I think it's going to be a great conversation. And so before we begin, I'm going to have us introduce ourselves.
Hi, I am Senator Martine LaRock-Bulick, and I represent Burlington, Winooski, Essex, and a little bit of Colchester. Nice to meet you all.
Good morning, I'm Dave Weeks. I live in Proctor and I represent Buckland County.
Ginny Lyons, and I represent Chittenden Southeast, which includes a lot of the smaller towns, little tiny bit of Burlington, Charlotte, Shelburne, Richmond, Heinsberg, St. George, Bolton, Jericho, Underhill, Williston, South Burlington. I think I got it.
Nice.
And I'm Terry Williams, I represent Rutland County also and from Fulton.
Okay, so we have been through S-231 previously with Ledge Council. So Joe, why don't you come up and start us out? I know you're on a time.
I appreciate being allowed to go first. Good morning, I'm Jill Mazza Olson. I'm the Executive Director of the VNAs of Vermont. I wanted to just start, I always do this when I testify, reminding the committee what it is that the agencies I represent do. Because there's always, I find that there's always a little confusion about that. People sort of seem to touch one part of our work and maybe not others. And so I just like to quickly give the full scope. So home health agencies provide probably first and foremost skilled home health care. So that's nurses and therapists in your home working under physician orders to provide clinical care at home, medical care at home on a short-term basis. So often that's after a hospitalization. Nearly as many people go home, are discharged to home health as are discharged to nursing homes in Vermont, to rehab. So we're playing a really critical role in the system in terms of discharging individuals from the hospital, preventing readmissions, which is hard to do with more complex people. And but we also take community referrals. So there are times when actually people come to us from primary care rather than from the hospital. So that's a really essential service we provide, much of it under Medicare, some of it under Medicaid. We also provide hospice services, so that's care at the end of life. Hospice is a holistic service with spiritual support, with goal setting, but also with pain management. So it's really a team approach of physicians, nurses, social workers, all kinds of volunteers to provide services at the end of life. And that is care you can have in many settings. So hospice is not a place, I always say it's a service. You can have it at home, you can have it in a nursing home. And then we provide maternal child health. So I'll leave that there, that we're definitely not talking about that today. And then we provide long-term care services. And so, we provide long-term care services mostly under the Choices for Care program. So that is Vermont's Medicaid waiver. So we have a waiver with the federal government to provide this long-term care service. Long-term care means, it actually is named, I think, relatively accurately. It services over a long period of time. There's no expectation that people will recover from long-term care. It's so whereas when you get intermittent skilled home health, the idea is that you have treatment goals that you'll meet. With long-term care, it's really that you're no longer able to provide for your own activities of daily living. You might need help with bathing or dressing, all of those kinds of things that we need to live independently at home. And so our role is to try to keep people in their homes as long as possible. And then often people ultimately are discharged from our service into a skilled facility at some point in the course of their lives. So that long-term care, I'm sorry, can you tell us, just give us an example of a skilled facility?
Oh, nursing home, thanks.
Yeah. So, the services are provided mostly by either LNAs or people who are not licensed at all, personal care attendants. It's a service that's really under threat. We have a really good benefit in Vermont. We've done a really nice job of trying to get as many services in the community as we can, but we have never paid for them. And so the wages that organizations are able to provide have not been adequate. It's not dissimilar to the childcare system, where it's unbelievably important, and yet somehow we can't seem to pay for it. And that program actually at this moment in time is under particular threat because of some federal changes where home health agencies are no longer going to be allowed to provide case management services. And those are services that have a whole clinical impact that are important. But just talking about the money, that's actually a piece of the program that has had generated some revenue to offset the huge losses in the direct service part of the program. So it's really changing the math for home health agencies as we contemplate this change. And it's happening already. Once it was announced by Dale, we started to see case managers make decisions about their lives. So it's already happening. So that is just by way of context for the comments I'm going to make. Actually, I want to say two more things. All of the services we provide are, there are many more people who benefit from a nurse in the home than we're allowed to serve and be reimbursed for. So the Medicare benefit for skilled services is pretty narrow. You have to be homebound, and you have to have a skilled need. You need a nurse, and you have treatment goals in the physician order. Medicaid is a little broader. You don't have to have the homebound requirement. So there's a little more flexibility for people who are on that service. But there are lots of people. It's really common for home health nurses to talk about how when we discharge someone from service, we know we're going to see them again in 3 months after the next hospitalization. And so we've worked actually in the healthcare reform space a lot around trying to figure out ways to fill some of those gaps. There's a pilot longitudinal care program through OneCare that allows us to actually keep people on service after they've been discharged. So we agree, I think the testimony you're likely to hear, there are many, many gaps and many people who need services for whom those services are simply not allowed under the structure that we have, under either the Medicare benefits. There's just no way to pay for it. So I don't think you're going to hear any daylight between us on the needs, the fact that there are needs out there. I think that's something anybody who's in this space agrees on. Where I think we have the disagreement is that we're just not able to support expansion of services until we pay for the services we've already built. And we have not done that. So $500,000 to us is, just to put that number in context, to us, that's a big number. If we were a different kind of organization, it'd be a bigger number, but look smaller, I think, in the context. But for us, that is our request to right down the hall for our skilled increase this year to get us just to 100% of the Medicare, what's called a LUPA rate, which is a lower rate, probably equivalent to about 75% of Medicare. So, you know, we have physicians at, many physicians at 100 or even 110% of Medicare. We've tried to bring other services to 100% of Medicare. We're well below 100% of Medicare. It's about half $500,000 in state funding to get us just to that 75% mark. And Devon Health has said no this year. So that's when we look at this, we're thinking about, we can't get these services that we're already providing funded. It's really hard to support an expansion. Our Choices for Care ask is about 1.11 or $2 million, which, sorry, I have my budget testimony in front of me. So what we've been, yeah, it's about $1 million in general fund, 1.1. So we're asking this year for a 15% increase in Choices for Care, direct service only. That's part of a 3-year process to try to bring those rates somewhere closer to cost. DEVA did a rate study in 2023, and they determined that our rates were about 50% lower than they needed to be to meet cost. So home health agencies are funded by Medicare and Medicaid. We don't have a strong source of revenue to make up for state shortfalls. We used to have a Medicare surplus. Medicare used to pay us more than we needed, and Medicare has made a concerted decision to close that gap. So they don't want to see a Medicare margin for home health, and they've been closing that gap over multiple administrations, different parties. It's actually been unfortunately one of the rare things people seem to agree on. And when they measure how we're doing on Medicare, they ignore migration to Medicare Advantage, which is some of those plans pay substantially less than Medicare, some in the Medicaid range. So we're struggling with the federal government and with their support for our primary services. And then we have a state that's really relied on us to subsidize those services in a way that we simply can't anymore. And so that's when we look at spending new state dollars on new services, it is not that we disagree on the need, it's that we have not yet funded the services that were already provided, that already have eligibility criteria. And there's some Medicaid programs, so there's a financial eligibility piece to it, as well as you have to be qualified for a nursing home clinically. So that's our dilemma. It is.
Can we get your dilemma in writing?
Sure, absolutely.
Okay, that would be helpful. All right, thank you. Okay. Questions for Joe?
So do we have are you able to service all of the home people that need your support?
No. So it really depends on the state, part of the state. So we're seeing certain parts of the state where it's really, really hard to get a nurse, even a traveler, to support that clinical service. But those are at my understanding, and the folks can correct me, the community nurse program is not working under a physician order. They would not be able to fill the gap of a skilled service ordered by a physician.
So let's let them testify so we
Sure.
can understand that. So, yeah.
So we got a bill up there, 162, which puts a moratorium on any additional home health.
We did that.
Yeah,
It's in the budget adjustment.
Okay.
Yeah.
So it's all done?
Well, as long as the budget adjustment act has it, it's still there.
there's no bill on that wall that brings us the 8,000 new nurses that we need in Vermont. That's the problem. So it's not about agencies. The issue is nurses. We don't have nurses, and we don't have nurses in, especially in certain parts of the state. So Windham County is a place where we're really particularly struggling in home health to find enough nurses for those skilled discharges. On the Choices for Care side, the personal care attendants, that's a problem all over the state. There's been a lot of competition with many other, we have a workforce crisis all across the state in many sectors and many industries. Those personal care attendants are not licensed, they're not limited to healthcare. They can work at the bagel shop. And so that is and because the program has been so underfunded, even with a lot of subsidies from home health, the wages are still not that competitive. We really try to make those wages competitive, but it's really hard. Yeah.
Okay, one last question.
If you can, just, can you kind of articulate the difference between the community nursing and the DNA program?
I think I'll let them do that.
I think we need to hear from the community
Yeah.
nurse folks, and then we'll.
Yeah, I know, I'm
begin
just looking
with-
for,
I think one thing to understand is that for home health, the skilled service that we provide is under physician order.
Okay.
It's under a physician order, so it's medical care under a physician order and it's under the Medicare benefit,
Right,
which is a limited benefit,
right,
yes.
that's helpful, does that help?
That is.
Yeah. All right, good,
If I've said anything you
Thank
think is
you.
wrong, please just, I'm happy to respond to that right now. Okay, you just,
so, but having your testimony in writing,
sure, happy to do that.
all right, good, all right, and then we, we may welcome you back as we go forward.
I'd be happy
Or
to.
not, we'll see how. it goes.
Okay. Thank you very much for the opportunity. I will stay for a bit. So I can
Well,
hear some-
Jill Lloyd is here, I think you're up next. Thanks for being here.
Well,
Hard to
thank
get
you,
back from-
Senator
from
Lyons, for
Puerto Rico.
inviting us to testify.
Yeah.
My name's Jill Lloyd. My career has been as a family nurse practitioner in nonprofit clinics for 35 years. I am the vice president of the Volunteer Aging in Heartland Group. I'm also the co-chair of the Aging in Heartland Community Nurse Program. I think I would wager to bet that everyone in here has had a family member, a friend or a neighbor who has needed, a senior who has needed healthcare, and trying to negotiate this very complicated web of a healthcare system that we have is very challenging. And I think if you look at this right here, you will see that kind of depicts that. The community nurse, you'll see that all these arrows go to, we have fortunately a lot of different healthcare agencies and programs in the states. None of them, including the community health or community nurse program, completes all of the healthcare or can provide all the healthcare needs of people. If you look at it for an individual trying to figure out who connects with what, where, when, it is very complicated. And I think that's where community nurse comes in as a navigator for clients. If you look at this one here, I would like to say, so the programs, when you look at programs, we have programs that are in each of the towns. Heartland, we have a lot of volunteer programs. Then you go to the local level and there's a lot of programs, and then the regional programs. I would love to say that they're all connected easily, concentric circles like this. Unfortunately, this is not the case. As we know, with Blueprint for Health, we've tried for years to get continuity of care. That's where we feel that community nurses can help link with that community of care for the individual. I'm gonna just read my testimony because I know we have a short period of time, and Katie's gonna give some testimony of actual examples of cases. From the start of our exploration to create a pilot project, we were tasked with defining key elements of our community nurse program that makes our program unique from other allied health programs and institutions, and outlining how we can help fill the gaps in the continuity of care of our aging Heartland population. Simply stated, community nurse programs are town-specific and bottom-up, facilitating seniors and their families' needs for social, emotional, and physical health, acting as both navigator within our complex healthcare system and acting as a client advocate, securing access to appropriate healthcare programs and agencies. Working in one town, community nurses have the capacity to respond quickly to referrals and the flexibility to adjust the frequency of meeting with clients as needed. Community nurses are not limited by policy restrictions on the number or time expenditure during visits, which fosters trusting relationships and continuity of care. Community nurses can make ongoing assessments to monitor each client's health noting changes which might indicate need for referral for further evaluation and care. Community nurse programs provide cost-free services to clients without regard to income or insurance eligibility. Community nurses assess the health and wellness needs of individuals and their clients, as well as gain understanding of overall needs of seniors. Aging in Heartland, community nurses identified isolation as a significant issue for seniors, which they brought to the Aging in Heartland Volunteer Board. Aging in Heartland has addressed isolation by starting a monthly senior cafe at the library, which is very well attended, and have applied for grant money to start a friendly visitor program. The community nurses also identified the need for more streamlined referral of EMS patients to the community nurse program, particularly for individuals who frequently call EMS. Unique to our Heartland community nurse program, we also have a volunteer group of individuals associated with Aging in Heartland who offer help with minor home cares, which the nurses can tap into when the need arises. We are excited to hear the interest of the Health and Welfare Committee regarding Senator Rebecca White's presentation at 2:31 on January 18th. After the hearing, I watched it and listened to the questions that you had, and I wanted to just respond to them. Can community nurse program be merged under the umbrella of VNH, the Visiting Nurses Program, or STASH, or for Senior Solutions, which is our area agency on aging. Community nurses act as liaisons for the clients to access as appropriate with any of the town, local, or regional healthcare programs and agencies, so would not fit under one umbrella agency. Where are the gaps in healthcare? No single healthcare agency or program addresses all healthcare needs of seniors. Community nurses act as ongoing client navigators and advocates in accessing their healthcare needs. What client eligibility criteria must be met for someone to receive services by a community nurse? Requirements might vary by program. For Aging in Heartland services, a client needs to be 60 or older and live in Heartland. Are community nurse programs competing for profit and nonprofit healthcare providers? No, community nurses do not provide direct medical care. I think answering your question you had just a little bit ago, and do not depend upon Medicare or Medicaid or private insurance for financial support. How can outcome measures be obtained to confirm benefit of expenditure? With outside expertise, the Community Nurse Pilot Project aims to develop tools to document cost savings, health outcomes, and measures of quality of life. What is the definition of a healthcare worker? Some community-based programs utilize healthcare workers rather than nurses. Instead of a healthcare worker, our pilot project is investigating hiring a home assistant to perform basic tasks like grocery shopping, picking up prescriptions, or doing light housekeeping. We are very aware that the most effective way to meet community needs will vary by location and over time. While we recognize common elements likely encompass the mix that comprises programs like ours, we believe that the structural flexibility and local autonomy are key to success. One-size-fits-all solutions can be tempting, but we think they are a trap to be avoided. That's my testimony. Should we wait for
Questions?
questions?
Any questions? So let's hear more testimony and then I will have some questions after that.
Okay.
It's just good. I don't want to preempt someone else's
Okay.
testimony. Who's next? You've got it set up, so, Katie, are you next? Thank you. That was great.
Good morning. Thank you, Senator Lyons, for inviting
I
us
just want to
here.
say, first of all, I like all of these things, the visuals. Go ahead. Thank you.
So to the Health and Welfare Committee, thank you for inviting me here today to speak in favor of supporting Bill S-231. My name is Katie Williams. I've been a registered nurse for 15 years. I worked for 5 years at Dartmouth-Hitchcock, 5 years with the visiting nurses of Vermont and New Hampshire, and have now been contracting with Aging in Heartland for 5 years. Today, I intend to share a few stories from my practice, which I feel depict how community nursing is unique from existing home healthcare businesses, and yet is integral in a regional health system. I want to emphasize all of this work would not be possible without the incredible town-based volunteers and resources. The nurse does not stand alone, but she is at the front line. I am reading a more consolidated version of the testimony you have a copy of. The highlighted sections that you see, I'm not reading, they're just extra for you.
I'm not, do we have Katie Williams on our page for that?
Just came in this morning. I don't know if you.
I just sent it in.
Okay, all right, yeah, we'll get it.
I have some paper copies
No,
here.
we're
That would
good.
be helpful.
We're,
Yeah, lovely.
Okay.
you
Yeah,
want.
would like one?
Yeah, I would too.
Okay.
It's not natural people who need paper copies.
I'm a paper copy person, so.
This isn't natural resources, I get it.
Yeah, I know, I also love the earth. Okay, so I'm gonna just read some stories that I've created. Some of the details have changed. I'm using different names to protect my clients' confidentiality and privacy. Frank is a 75-year-old man who grew up 10 miles from where he's currently living. He's deeply religious, kind, never misses an opportunity to get a mailing address and birth date from the people he's actually fond of. He did not marry or have children, and he lives alone. We have been working with him continuously for 5 years, meeting at least monthly and at times 3 days a week, depending on the acuity of need and what other services may also be engaged. He has untreated PTSD from early childhood trauma. He is deeply isolated, severely obese, and is considered homebound because he requires wheelchair transportation to leave his home. His monthly fixed income of $2,000 just barely misses the mark to qualify for most services, including choices for care. He pays out of pocket for all assistance. Upon our introduction, he was already enrolled in SASH but had no medical doctor. He had concerns for diabetes, cardiac disease, chronic pain, and chronic skin infections. Immediately, the community nurse, who was Jill at the time, requested special consideration for a home-based primary care program from another hospital. The client was accepted. Community Nurse Connect provides all community nurses with an electronic platform to communicate directly with DH systems, including VNH. Because this client is unable to leave home, he cannot just schedule himself an appointment and go to the clinic. Visiting nurses provide services if there is a Medicare-approved reason for being in the home. VNH has had multiple intervals of care during these last 5 years. However, they have always had to discharge Frank once the wound was healed or the rehab goals were met. In chronic illness, the next healthcare issue is just around the corner. The community nurse's continuous care allows the next issue to be identified and addressed ahead of time. I remember one visit when I identified a wound. I was able to call primary care and send photographs. They in turn sent a new prescription for infection management and made a referral to VNH to initiate services. Over the years, our interventions have been countless. The community nurse has facilitated home modification, delivery of essential goods, identification of multiple caregivers, medication education, symptom management support, transportation, and friendly visitor assignment. Most recently, I have been a part of a multidisciplinary approach to support the client to return home after an extended hospitalization. Frank has made the courageous decision to die at home rather than attempt rehabilitation in a skilled nursing facility which would likely result in permanent residency. Story number one. Story number two. I have an image saved in my phone of two hands, my own and that of a client. It is a picture I took when I was at the bedside of this person that I cared for 4 years, while she was eventually dying. I was honored to witness her final passing, but I also witnessed the very long and difficult journey it took her to get to this final surrender. As a community nurse, I supported her to find a new CAD, placement for rehab care, caregiver training, a new recliner chair, and a volunteer to help make modifications in the home for fall risk reduction. I spent countless hours listening to her life story, building trust, and offering companionship. She decided to let go of her driver's license, and we made sure she had emergency plans for power outages. This person invested much meaning into the practice of work. She was a technical teacher in the Vermont jail system, a mechanic, an engineer. When she could no longer use her hands, when she could no longer problem solve, she knew that it was time to let go. At one point, we had a joint visit with a SASH coordinator who suggested that she might now be a candidate for hospice care. There was a 2-month period between that joint visit and the next. Within that 2-month period, the community nurse ensured that the primary care doctor made a referral to our local hospice facility, Viata. We worked together to gradually introduce new team members. Eventually, the hospice team replaced the primary care team, but still the community nurse remained. We arranged final family visits, ate graham crackers with milk, and read Agatha Christie out loud. She eventually qualified for the Death with Dignity program. The client at one point stated, "I couldn't make this decision without you. You know me so well." The 100+ visits I made with her were free. My visits were not defined in duration or length by her medical insurance guidelines. I was integral in her hospice care. One day I came to her home in a routine visit, and she and the bed were saturated in blood. She had been having reoccurring nosebleeds because of her COPD treatments and condition. Rather than call the rescue squad, we called the hospice team. I sat with her, gave her a bed bath, coordinated with hospice, and together we triaged her care. The rescue squad didn't need to be called, and the hospice team didn't need to come. By the time I left, she was clean, calm, and stable, and the hospice nurse was planning for her routine visit the next day. Well, I have time for one more story. That's short.
Sure. We'll go until 11 o'clock with this. That'll give us plenty of time to finish our group.
Finally, and not last in my heart's awareness, is a client that was really a fighter. This woman was 94 years old when she left us and was basically independent up until the age of 93 and 1/2. I met her 4 years ago at a blood pressure clinic. She attended the community breakfast and clinic that's organized by Aging in Heartland weekly at our local church. Initially, she would only occasionally welcome me to her home. And when she did, she wanted me to know that everything was fine. Truthfully, everything was fine until it wasn't. We were called in when she had had a fall and had been hospitalized. By this time, over gentle and non-urgent introductions, we knew each other well. The fall itself was not too bad, but unfortunately, the hospitalization was extended because she contracted COVID while staying at Dartmouth. By the time she was home 5 weeks later, her cognitive status had changed. Deep isolation will do this. She lived in a trailer that was placed in the same lot as her grandson. He and his wife had been this client's primary support system for at least 10 years, though throughout much of that, she had been quite independent. She would always pick up beets at the food shelf, and she would tell the nurse, "If you boil the beets and drink the juice and waste nothing, you will be strong in health." When her health turned after her fall, it was very difficult. She was discharged first to a rehab center and met all goals there. She was then discharged home with services from our local VNA. Rehab worked closely with her, but she consistently, because of her cognitive changes, refused cooperation and was discharged for not meeting progress goals set forth by Medicare. This left the community nurse and the primary care team, who at this point was home-based. Home-based primary care is only able to visit monthly. The community nurse provided 3 visits per week and communicated with primary care at each visit. Some of these visits were crisis management as the family felt powerless and helpless. They wanted to call 911 because they didn't know how to handle the client's increasing senility, her threats to burn down the house and attempts to disconnect the power. Calling 911 would have been fruitless. She could not receive inpatient psychiatric care, and she was not yet qualified for choices for care, thus unable to be transferred to a nursing home. The community nurse was the most consistent in-home service for the client and their family when no other service could be in place. Eventually, this client chose to end her own life. While she experienced cognitive changes in the end, there were also periods of lucidity. She knew that she did not want to live in a nursing home, and she knew that she did not want to live at home, requiring significant 24/7 care from her family. The family wanted to, but could not give this level of care. Her passing was peaceful and ultimately a reflection of what she truly wanted. Thank you for listening.
Thank you. Senator Bullock.
Thank you for those stories. They were really educational for me and also just very poignant and I really thank you for taking the time to share those with us. I have a question about the last story that you told. You mentioned that calling 911 would have been fruitless, that she was not yet qualified for choices for care. What does that mean exactly?
So for somebody who is low income and cannot pay out of pocket for a nursing home, they need to qualify for choices for care, which is long-term Medicaid in the state of Vermont. And there's a certain process that you need to undergo to qualify for that. And it's income dependent, it's also healthcare dependent. In many ways, she would qualify based on her fixed income and her health profile, but she had to spend out her money. And she was working, they had an active application going on. There was kind of a pending referral to an institution, but it was going to be a few weeks. Primary care was involved, helping as much as possible. It was a little bit about waiting for a bed, but there was kind of this 2 to 3 week period where the family knew if they called 911, she would just be discharged home a few hours later. So we really had to navigate, how are you going to manage this crisis from home with the resources you have here?
And just the incidental for long-term Medicaid, in terms of spending down, you can have $2,000 a year in your bank
In your
account.
bank account.
So that obviously excludes,
It's difficult.
yeah, a lot.
Other questions?
And the process to apply is very complicated.
So the question I'm gonna ask, I think, is going to be, will someone be talking about how your services are funded?
Yes.
That's Bill, okay.
Nothing's free, but yes.
No, nothing's ever free, but there's a lot that's happening here, so we want to know. If it's not Medicare or Medicaid,
Yeah,
you need to know, yeah.
of course.
And if you're not eligible for that, you need to know. So, thank you. We do not have your testimony. Can you send it to Kiki?
Yes, I attempted and it bounced back. And then I attempted again.
So,
Representative Holcomb gave you the wrong mailing address.
Okay, I will absolutely send it along.
okay, and then leave me a copy until I get that. I'd like to have a copy. Thank you, Eric. Thanks.
Thank you very much for your time.
Thank you. Thanks for the story. The stories are very compelling, and I will say this. One of the concerns that we have when we appropriate funds for pilot programs or any organization is to have some indication of outcomes. So it's whether it's both qualitative and quantitative. So that's just like a heads up going forward.
I think Phil's are you gonna talk a little bit about
Okay.
that?
So,
I'll try to,
Yeah. Go ahead.
okay,
Well-
I'm Phil Hobby from Portland. I'm on the board of aging in Portland, and I'm also chair of the Heartland Select Board. I'm currently trying to understand the marble industry and Rental Proctor's biography and how, and why the granite industry continues and marble doesn't.
The green
Good
marble
question.
especially.
You look familiar.
I have Vermont Birdie.
Oh.
I'm sorry.
I said you look familiar.
Okay, I was in the livestock business for years. Professionally, I had 40 years in information technology with business systems and over 30 years in higher ed systems, student systems, financial systems. And so, I worked for about 6 months as a volunteer for the Center for Organizing Rural Health Equity, the new group coming out of the Department of Health. My role was to, as a layperson, try to go through their vision and their strategy to make sure that it was understandable. But equity is the key word there. I also, after leaving Dartmouth, I started a business after caring for my dad called Vermont Home for Life. And it was really to address the aging in place market. I ended it after 2 years because I think it's significant why. The calls were coming in saying my parent or my partner is coming home tomorrow. Can you come tomorrow to put in grad bars and so on? And my vision for the business had been more proactive and it just wasn't there. My work as a select person is about building and maintaining community. I work with town commissions and committees as well as the many volunteer groups to run, as well as enrich the town. Of course, the select board must keep the public buildings and roads maintained, provide core services like safety, fire, EMS, and library services. For me, the goal of building community has me framing decisions considering the economic realities as well as our physical and mental health of our town. Today, I'm here to represent Aging in Heartland and our community nurse program. Aging in Heartland is 10 years old. It could be 12, but their older records are fairly loose. As Katie and Jill have described, we have 2 community nurses, a part-time administrator, and many volunteers. We have an online referral system, volunteers to help with referrals, a system to track donors and volunteers, and the nurses use RedCap system, which Katie can speak to better than I. Our budget includes an appropriation from the town, private donations, grants and income from fundraising events, and an annual appeal. The appropriation from Heartland is roughly 35% of AIH's revenue. I think it is very significant that our town chooses to support Aging in Heartland to the extent that it does. I think you're all familiar with how appropriations work. 28,000 is a big one on that list. I would like to reference some thinking on the topic of community and relate this to the community nurses. Peter Block, in his book, Community, the Structure of Belonging, offers many suggestions on ways to create and build vital communities. In the book, he talks about our love of problems. As a society, we believe that defining, analyzing, and studying problems is the path to a better world. The creation of a community nurse pilot will enable more definition of the benefits and liabilities of town community nurse programs. But I want to speak to the core of Block's premise, that often we do not need more studies, and the answer is right in front of us. Aging in Heartland Community Nurse Program works. The program is over 10 years old. We have built trust in the community nurse program in our town. Our referrals to the community nurse program continue to increase. We have programs that the community is aware of and participates in and values. Please consider our community nurse program as an example of why funding and conducting a statewide set of pilots is valid as well as important. So quick off-the-cuff comments. I had prostate cancer, and some years ago, it metastasized on my lung, and I had a visiting nurse come and care for the dressing. I got a mild infection, but they couldn't come anymore because it wasn't funded. And that's the dilemma and the primary difference with the community nurse is. I hope you see that the community nurse program meets all the equity standards that we strive for today. But the funding is really grassroots, and I believe the funding that we're asking for a pilot would hopefully be seed money for nurse programs to start and not necessarily fully to fund them on an ongoing basis. And I've given the limited funds, I feel that's the best use of that. There are some systems in place that we use. I have the budget for a fairly crude database system that we have. The hardest part is how do we measure the stories that Katie tells? How do you quantify that into proof that this is a program that is effective? We
Sounds
can,
good to me.
yeah, exactly. But you know, I was of a generation in the programming field that we started getting hammered for knowledge management and all that
Right.
stuff. So thank you. I appreciate your consideration.
Thank you, and so I say that I understand what you're saying as chair of the select board, having an interest in human services in the community.
Yeah.
When I became chair of my select board in the 90s, the first thing I did was to establish a social services committee and to put in place some support services for folks who were at home, whatever they needed. So it's refreshing to know that other towns, municipalities are doing similar things. It's just really refreshing because there was so much pushback that we got from some folks about using taxpayer dollars for somebody's care.
And you can appreciate the pushback we're getting where communities are beginning to add a health chapter to their town plan.
Yeah.
Which I think would address a lot of these issues. And I.
Echoes. Right.
Yeah.
Yeah, we worked on that too.
So I would have to say, when we presented for the town for this big increase, requesting the 28,000, that we had all of our responses all prepared, but we gave actually Katie gave a wonderful presentation, and there wasn't one person that.
You have a good select board.
Yeah.
Yeah.
So I do have a question, and I don't know whether it'll be answered with Caroline staff or not, but the question is about how the funds would be utilized. So you're asking for funding for a pilot program, so to getting a
Sure.
budget.
I think we can begin to answer that.
Yeah. I think we could open it now. It's quiet out there.
Yeah, let's do.
Yeah.
Do we know how many of these owners programs there are in the state? I can't remember if.
Very few.
There's, I think there's 13.
If you go to the Community Nurse Connect website, they have a list of all of the existing programs. I believe we're up to 16.
Oh, 16 now?
They are growing rapidly.
Yeah, last time it was not long
It
ago.
was like 9 last year.
So it's filling gaps. What we're talking about are filling gaps that can't be accomplished using our current financial system. So let's go to Carol. Thank you for being here.
Thank you. My name is Caroline Steph, and I've had a stroke, so I talk funny. I think reading is best.
We like reading.
I'm here to support the bill 231. And so I bought my place when I was 21 in Sharon. And I've lived here almost 60 years. Now I want to age at home. I love my place. I grow my food, raise my kids. I think that Vermont is really about a sense of place. And each town is very different. And the town of Sharon is spread out, many isolated people, no central community center. Also, it's a long way to hospitals and doctors. I feel the need to have someone to help me now. My medical and physical problems. And we have a healthcare coordinator person. It's a godsend. Both my husband and I call her and she comes when needed and helps talk to us about many things. The person we currently has is trained in occupational therapist. We had first a nurse and then the social
And
worker.
what's happening? Okay, yeah,
I'm
thanks.
sorry,
No, that's okay. He was talking too loud.
So we heard a nurse first, this being going on for 9 years in Sharon. And then a social worker had been a nurse and the nurse and then now our OT. And we learned from the social worker, many of problems, mental health. So we kind of upped our care about this part of the thing. So this OT person is great because I'm less and less able to do physical things. And she helped me learn new ways of doing things and made our house more safe. So she also helps many people to find services they need and find volunteers to come and chat you up and gets volunteers to take us to doctors. She's kind of a what advocate you need in your family, but not plainly. This is better.
That makes sense.
So one time I had an incident and I drove down and meet the ambulance in the town and had to talk with them, what should I do? And I can drive myself to the hospital, a friend who drove me. But it was a complicated thing. Now I can call Dina and she can explain what to do. So I want to talk about the effects this person has on our community. A lot of rescue gets calls from people that have questions and they don't wind up needing them to come. The Dina, the healthcare coordinator, can come instead, explain. So all the rescue, not many rescue services visits go down, saves money. Also, assistance scoops up many people that can't get proper treatment. We have similar stories where it's an old man, he's living alone, he used to be a fire department, and he ran out of wood and her water wasn't working and he's going blind. And Dina got him the fire department could come in a work party and got the wood and the water. And she eventually got him to have the doctors cure his blindness. So it's a happy ending. More violence, overall, the effects of having healthcare coordinated in our town is very important. More volunteers get involved, learn about people who need visits, need food, medical help, and it kind of bring community together. We had potlucks in each neighborhood and introduced the current coordinator. It was a fun thing to do for everyone. People sometimes confuse visiting nurses with a community nurse. We've talked about it a lot. It's very different. the community nurse or health coordinator, they're there all the time and can carry through. And can't change dressing, but can teach you the family member to change a dress. So it's almost hands-on, but not quite. The visiting nurses does that. They're not doctor driven, they from the town. People who need it. Lisa Franz and Bryce. It's the same thing that for those situations which healthcare services are not available or are needed. It provides a holistic approach to helping people get their needs met and be safe. They're free for anyone in town, and no reimbursement, no charge. Therefore, on a continual basis, a person can trust. I realize many towns bill their nurses differently. So I tell you how we started. I was working on the show, a big dance piece outdoors about healing for flock dance troupe. I went to see Dr. Dennis McCullough, and he was our family doctor, lived with the babies. And I talked to him about the essence of healing, and he said acceptance. So I was struck by that, and he told me about the community nurse idea. He was the one that started back up here. So I put this idea into my show. The man in the show, the young man, got paralyzed. And at the end of the show, the community nurse comes and helps the family navigate concerns, all the things he needs, and gets volunteers to come and support him. And after the show, I got calls from 2 towns. We want a nurse. How do you get this? So I started in Sharon. I live in Sharon, but I'm connected to Stratford. And we met people interested. And the first thing we did was got into town plan. It was just being redone. We got wording into the town plan, and then there's a document, and then I said, and the Regional Planning Commission helped this process. And then we went to town meeting, I talked about it, and the person that had this question, I put her on the board. And we proceeded to get some money from the town right away this first year. And then the Upper Valley Community Nurse, now called Community Connections, they gave a startup grant $5,000. They still do this. And then we raised money from the town people, got grants, and we're off and running. I guess you'd hear what the person did. I guess I want to say that I think the regional town commissions are a good place to make a template to help towns plug this into their system of, goals on the town plan and get things started. So they have whole health documents anyway, so it's this. So my ending thing is there are many more people here now in the world, and it's really messy. A lot of staff shortages everywhere and complicated to go forward. But I believe there's some way to get the towns to stay in their structure overseeing these nurses and join into an agencies already in place. The big health plan is really good and needs this part to fit the gap from the towns. So I really think that's the job on hand, how to fit these things together.
Thank you, and we all are familiar with how important community support is. And back in the old days, before we started our town services commission, before you started doing your work, we used to take stock every Thanksgiving. How many families need a turkey? I mean, it really is, Vermont does have that tradition of community support services.
Yeah, the other measure, how many more lunches are going home, or how many.
How many kids
meals
need to take the
are going home on
backpack?
Friday.
You're right. Thank you very much. We have one question and then we're gonna move on.
Just, we've got all the ingredients. You guys are baking the cake in my town. So the biggest concern that most people in my community have is liability. So how do you handle insurance?
I purchased malpractice insurance.
That's for you. What about all the other people?
And the organization reimburses us for that, but there's also a
Yeah,
workers' comp.
Asian and Heartland carries an insurance policy. I could follow up exactly with what the amounts are and where.
Yeah, so I think my previous question about what is your current budget, where's the money come from and how do you sort it out?
Right.
And that's what the ask is, in the bill.
Yeah, we can provide it.
Oh, good. So if you can send that information to Kiki,
Okay.
and then we'll have it on our webpage for reference. That would be very.
Do you have a business card?
Review it, not today. We don't have time today, but we can look at it. We will come back, we'll come back.
Thank you.
Yeah, thank you. But do you have that electronically that you can share
Yes.
both for the 501c3 and what the municipality is doing, and then the insurance question? Because that would be in the budget, I would assume, and then what the budget is in the request, in the appropriations request. And that's it for today, but I can't tell you how much we appreciate working about.
Thank you.
Yes, great.
Thank you. Senator White?
Thank you.
Are you all good?
You're good.
Thank you, Madam Chair.
Debatably so.
Thank you so much for having. us.
Yeah, no, terrific, thank you.
And can you send it?
Yeah. So Katie, we're gonna let everyone. So you're.
The website is really good, by the way, the Community Nurse Connection.
Yeah,
Really good.
they're integral
Yeah.
in every community and they have templates and.
Yeah.
But that's only for one part of Vermont, right?
Yeah, it looks like it's the south.
But it's
corner.
what we call the Upper Valley.
Yeah.
I think
They're willing to expand though. They're supporting programming in Maine.
I mean, really
Yeah.
quick.
And Portsmouth?
Like,
Okay. Well, it's in New Hampshire as well, so.
Yeah,
Yeah,
they,
there were originally more in New Hampshire and Vermont was.
we're on that Twin City
Thanks
corner.
for all you do.
Thank you so much.
thank you.
Thank you.
Terrific. Oh my God, it's gonna be a very long day.
I know,
A lot of input, baby. We
but
are.
you are good.
Yes, yeah. Hey, world. Just sharing my. I knew it was there. Yeah, after a while, yeah.
Okay.
Ooh, I'm just like. I go for the fatty.
Oh, what's next?
All right, so we have another little bill that we're working on, S-189, the mental health response service protocols, and alcohol guidelines. And Katie, we have a new draft.
You do, it's draft fix one.
Okay, let's find that and look at that.
Great. Katie McLennan, legislative council. Here's draft 3.1.
When we last went through the bill, you made just one change or did just one change to the existing language, which I will show you, and then you had folks representing social workers come in and they asked for additional language, so that is a new subsection of the bill or standalone section. So if you recall, this is the mental health response service guidelines, not protocols any longer. In developing the guidelines in subsection B, the department is to consult the following entities. And the committee asked to include the Vermont Criminal Justice Council. So that's added on page 2, line 4. And then you requested a new section of the bill on social worker provider safety. So this would be a presentation.
Can we walk through that?
I will, yes.
Yeah.
On or before November 15th of this year, AHS, in collaboration with the Vermont chapter of National Association of Social Workers, shall convene one or more meetings related to social worker provider safety with community-based social service organizations. And we have the list of the organizations and professions that may be included in the meeting or meetings described in this subsection. So these are stakeholders who could participate. The Vermont Network Against Domestic Violence and Sexual Violence, the Vermont Coalition to End Homelessness, mental health and healthcare providers, community action programs, restorative justice service providers, and disability service providers. Top of page 3, in advance of the meeting or meetings that are being described in this subsection, the participating organizations and professions may review both studies related to social service provider safety and also individual social service provider safety experiences. And then by January 1 or 31 of next year, AHS in collaboration with the National Association of Social Workers is to present findings and recommendations to various subject matter committees, including a list of the organizations that participated in the meeting or meetings and the number of meetings convened.
I'm trying to, I think we had wanted to have something about first committee being called no later than, that's the date we had settled on, the September 1st.
Okay.
And other than that,
There's there's not a requirement for multiple meetings. It's optional if they want to have more than one meeting. Let's see, they shall convene one or more meetings no later than September 1st.
yeah,
That would mean that all of the meetings are held by September 1st. If there are multiple, is that what you want?
I'm
no,
not sure it's
can't do that.
necessary to put a date in, they can.
I just want to make sure that the meetings get called, because the date for,
Oh, well, they have, by November 15th, they have to meet, on or before November 15th. Sorry, I was thinking that's the report back date.
okay, we did decide on that, I guess, okay. I just had September 1st built in my brain.
Oh, but the policy
That's
choice,
fine.
it can be changed.
No, it's fine. That's fine. Questions for Katie on this? So, we did some work on the bill a little bit. So. Do we need to do more is the question? I'm not sure we do. Then Joyce, we can bring this up for a vote today, tomorrow, or Friday.
I mean, has everyone weighed in who wants to weigh in?
Yeah.
No?
Yeah, we have pretty good list of estimates. And then the social worker came in last time.
Right.
to add.
I don't know, I guess I'd say today or tomorrow.
We're starting at 8:30. Better time, maybe. Maybe you're not here tomorrow, but that's probably okay. Or not?
Me and I can be, I'm booked from 9 to like 11.
So maybe we could just insert, before Michelle comes in, or after, at the end of the day. Let's put it at 11:50, would that fit?
Perfect.
It is, okay, let's do 11:50, we'll have, council to vote for, 189. Okay. Next bill is a little more complicated. So as you know, may not know, agriculture, we've been working on sections 6 and 7. And made a decision to strike those two sections completely. Apparently in December 2023, the EPA, put out, worked with, I'm trying to get straight with, they worked with and put out information regarding the inclusion of PFAS in, containers, or they asked one manufacturer or demanded that one manufacturer no longer put PFAS in containers for the things that are in, agricultural, products that are in section 6 and 7. So given that that happened, believe that the agency testified to the Ag Committee. They decided to take out section 6 and 7. We'll confirm exactly what has happened with those two sections. Meantime, we're looking at additional information from ANR, Matt Chapman and others, including Kyla Bennett, who has testified here twice. So let's look at what we have left for our sections, and then I will be talking with agriculture about the sections they reviewed. My goal would be to keep something going forward in terms of agricultural products that are either articles treated or containers treated that contain PFAS. There we go. Another day, another complexity. You're all set for all kinds of complexity.
Here is S197. This is draft 2.1. When we last met, you had, maybe a couple weeks ago, you had asked for language about educational materials. And I brought back that language for you. It's on page 2. This hasn't changed since the last time we walked through the bill, so I might just pass over it for the moment. But what has changed is instead of looking at restricting PFAS and going ahead and mechanizing that, this is a report back. It requires the Agency of Natural Resources in consultation with the Agency of Agriculture and the Department of Health to propose shall propose a program for restricting the use of PFAS in consumer products. And then the recommendation shall identify consumer products that have high concentrations of PFAS or have a high potential for release into the environment. Establish a process by which manufacturers determine whether a consumer product contains PFAS. Address how information about the presence or lack of PFAS in a consumer product is conveyed to the public. Describe which agency or department is responsible for administration of the proposed program, including what additional staff or information technology changes, if any, are necessary to implement the program. Determine whether and how other states have structured and implemented similar programs and identify the best practices used in these efforts. And lastly, propose definitions of intentionally added consumer product and PFAS. The Agency of Natural Resources is to obtain input on its recommendation from interested parties, including those that represent environmental and industry interests. By November 1 of this coming year, the Agency of Natural Resources is to submit recommendations developed pursuant to this section
and corresponding draft legislation to the various policy committees.
So going to scroll back up to the,
Right there?
down. It's bit there. So, including those that represent environmental and industry interests, should we also add agricultural?
We can.
Recently, the Agency of Agriculture has added a public health expert and, someone who was working in this area for, looking at chemicals of concern. So should be included, being more inclusive. And we've received a letter from the veterinarians. Yes, did you see that letter? Did everybody get that? Maybe not. I'll have Kiki put it up. But they're concerned about the PFAS in tick collars and, you know, for dogs and cats. Go ahead. Yeah.
In one, page 3, identify consumer products. I think that's a little too vague.
Yeah.
I'm wondering if we could something like types of products or classes.
Yeah, there's a better way to word that. I agree.
Something like a group, because I don't know if you want to be like, okay, this pen and this piece, you know, these products or scissors, or you know what I mean? I think we need
What's the
more
goal? Yeah, this is the question. What's the goal there?
types of products.
A system for, yeah. I think what we want to see is a system for having reporting about and PFAS there, so, you know.
Yeah, I mean, I just imagine that there are thousands and thousands of products.
With thousands and thousands of PFAS.
Exactly, so giving them a more defined way to determine which products we're talking about might be helpful.
Is it more products that would have a direct health effect or environmental effect that might more directly affect surface and groundwater? I mean, how do we want to say that? That we're looking at a link between environmental health and public health.
How about identify consumer products? Don't write this down yet, I'm still thinking, I'm like, something like that, that have, an impact on public health and environmental safety, or something like that.
Yeah.
That have a considerable, significant,
High
yeah.
potential for release into the environment, resulting with possible effect on public health. That. How do you want to say that? Your
Sorry,
words.
I'm writing down all the ideas.
Okay,
See
good.
where that, yeah, so I think it makes sense to say something like identify types or classes of, you know, if that makes sense.
Yeah,
Good.
With the recommendation on human health and environmental safety. I don't know if environmental safety is the right phrase.
Health in the environment.
Public health.
Environmental contamination. Well, Kitty running around with the tick collar.
and also, I'm confused as to whether this proposed program, if their recommendations are supposed to identify the products, or if their recommendations are supposed to propose a means to identify the products, and similarly propose a means to establish a process.
I think that's a question we have to ask, Matt Chapman or Brendan Atwood. Can we get an answer to that question?
Yeah, I think so. Brendan Atwood, Department of Health Policy Director. So I think the intention here is that if the legislature decides to not do a broad-based ban on PFAS, that we can provide a list of types of products that can be evaluated for prohibition on a product basis. So that section right there just pertains to dealing with that list, and I think the rest of it is more in line with the process that you're talking about, Senator.
But the recommendations shall establish a process or shall? The establish, because the recommendations are not going to establish the process. That's the, I think what I'm getting. There's to propose a process.
Yeah, and then so one is just talking about kind of what that list might be that might exist outside of a process. So we'll come back proposing a process for the legislature to consider which products are exempt. Sorry, Senator, go ahead.
You're gonna come back with a process when?
Well, that's what the rest of this language in section
Right.
2 is proposing
Okay.
to do. And one is kind of it's related, but in the absence of implementing a process and a program, we'll at least have a list of types of products available for the legislature's consideration on a product basis about whether or not to consider banning or limiting those products. So it's kind of supplemental to the process that's envisioned.
We don't wanna ban the product, we wanna ban the PFAS of the product. But, yeah,
Right, these would be a list of the priority products that would be, of most concern, and.
okay, so there's two different things then within that one recommendation section. Okay, what do you think?
Well, I think. Yeah, I think you have to, is the goal of this to, what you were just saying, is the goal just to identify products that are problematic? Or is the goal to restrict either the product or the use of PFAS in those products? I think. Which of those policy options, avenues you're interested in pursuing, just to be clearly stated?
Well, we would like to restrict the PFAS. So we're looking to, the manufacturers will have to decide, do they have an alternative to that PFAS? We can't tell them to change it. We can just say, no, we don't want to have this list of products sold in the state until and unless PFAS A reaches a certain level or is no longer present. That's what I think we would like to see coming back to us. And so I'm looking at number 2, for example, and looking at number 2, which is really there. Establish a process by which manufacturers determine whether a consumer product contains PFAS. So we're asking the manufacturers for certification that it's there or it's not there at a specific level. That's a big deal. I don't know how better to say that so it's explicit.
I think actually. What I might recommend is working on the lead-in language, so it's clear sort of what the goal is. Right now, it's pretty vague. Propose a program for restricting the use of PFAS, but in consumer products, but what is the goal? So if the goal is to, it's a program to have manufacturers identify which products have PFAS, and that the health department or whoever is going to identify products with high concentrations. And the ultimate goal is to restrict the sale of those products containing the high level of PFAS. I think we should just sort of spell out what the goal is and the introductory language, and then sort of lay out the specifics.
Yeah, and that goes to the discussion about the environmental problems, public health. Problems. Okay, let's do that.
Okay, we're gonna try.
All right, and then the types of products. I think is important clarification. And then,
Oh, rework this one, so we're talking
Yes.
about public health and environmental. Contamination. Ready? Then you also asked for that in 2, pose instead of establish.
I mean, if the goal is to eliminate thousands of PFAS chemicals that potentially leach out to the environment or to humans. Um, okay, number 3 works. Just looking at the language here. And so they're gonna propose the program for doing this, so that's there. Who's doing it? Okay. Any other suggestions on that?
And 2, I wonder if you might want to specify to whom the manufacturers are identifying this information. Is the intention to give it a process? So I mean, you could just leave it vague and then the group or A&R is gonna come up with a process that they recommend.
Yeah, I have a feeling that Matt Chapman's already working with other states on this, so leaving it in his language is helpful, right? What comes after that? I don't have any. Potentially added consumer product or water. Yeah, okay. So I do know that the EPA has sort of said restrictions on, I think, between 6 and 12 different PFAS chemicals and thousands of them. I hope we can do better. Sorry. Okay, no, they're just notices of meetings. Okay. Anything else there on B? What B is what? Input recommendations from
We added agricultural interests.
agricultural. Okay. All right, and then anything else there, committee?
I'm still confused about what this is gonna look like once it's in place. But I'll try to.
Well, there could be, do we want to have the Attorney General included in this? Because if there's some kind of a certification process or assessment, the Consumer Products Division in the AG's office may want to be included.
Should I add them as
Yes.
folks to consult with?
Yes. Please.
Okay.
Because then, so then the manufacturer, it could be something like this, Senator, it could be this manufacturer is producing these types of products and they are providing a certification notice to Department of Health that the PFAS level is below the level of concern. And so then those products would be out on the market in the state of Vermont. We can say that anything that doesn't have that level or below will not be sold in the state. We can do that. And then there has to be some, there might be some spot checking for products. Big deal. So. Do we want to go back up to the education piece? Or do you want, are you?
No, it's okay with that.
What are we asking for at the end?
You're asking for a report and draft legislation.
Okay. Can we ask for an implementation plan?
Instead of reports?
I don't like reports. I like an implementation plan that's reflected in draft legislation.
Okay.
Does that make sense to people? And then we'll deal with sections 6 and 7.
So we ask them to develop an implementation plan based on their findings.
Yeah.
We ask them to take action for in regards to their findings.
Well, they're not gonna be able to do anything until I think they bring the plan back to us. You wanna tell them to go forth and do it, that's one thing, but they might do something that we're not thrilled with.
Right.
might do something that's over the top, you know, and so I.
So the intent is a study, they come back with recommendations.
For an, yeah, for an implementation,
With an implementation plan as part of the study.
yeah. Yeah. So I'm not interested in having 100-page report as much as I am the appendices and all the data that they're using to support implementation.
Section 6 and 7, you don't put back in.
Oh, I'm not putting that in. I'm gonna talk to Senator Starr about them. Maybe there's something we can do to encourage that committee to, have language that takes us forward. And we did hear testimony from, Kyla Bennett about the importance of this. Anything else on this one? Oh, we have one more thing to do. Alright, we're okay with this one? We'll get the language back and take another look at it. We can talk about when that.
You're picking it up again on Friday. Do I have you on anything?
Yep, great, you're on Friday. Okay, perfect, that's good. Oh, the general, we do the Sergeant of Arms on Friday?
Yes.
Oh, why did I think it was tomorrow?
Is that what you?
Okay, I don't memorize it. Okay, so 192, let's go back to that proposal from amendment. Yeah.
Oh, you have the.
This is the amended financial that we looked at this morning, and if you recollect, there was a few second instance of amendment. And the question was, who would like their names added to the amendment? That's who we are.
Okay. Good.
It's 3 o'clock.
Yeah, I'm Senator Williams. Okay, all of us,
Everybody.
put it on, and then I can carry it upstairs.
Okay.
Hopefully this is the last.
I don't believe it. I'm sure there's gonna be something else.
Nothing else. This is, there's so many technical issues here with cross-referencing between Title 13, Title 18. Well, that's Title 33, it's Title 33. No, 33, it's 18. Okay, all right, well, thank you all for being, so engaged today. We've done a lot of work, got started on some good stuff, really appreciate it. And we did finish early, don't know why, but
We started with.
yeah, so tomorrow we're starting at 8:30. And we will